So a patient with Crohn's disease is doing poorly on mesalamine, probably shouldn't have been on mesalamine anyway, and a change to more aggressive therapy is planned. She's been on high-dose steroids for 2 months. What should we be doing? So we should be doing a TB interferon gamma release assay. We should be begin to taper off the steroids, assessing for hepatitis B, and vaccinating if negative, or all of the above. All right, excellent. So all the above is correct. I think I'll editorialize and say you may not want to taper the person off the steroids until you actually get them started on the next therapy if they're really doing poorly. But yeah, the goal should be to get them off the steroids. You want to check for TB, you want to check for hepatitis B before you start some of these biologic agents. All right. Okay. So a little bit on thinking through how you might treat some of these patients. Again, these are always going to be in combination with a gastroenterologist. The 5 ASAs we spoke about at the beginning, not used very frequently in Crohn's disease, but you can use it particularly in colonic disease. You can use prednisone or budesonide, both steroids, trying to avoid them as much as possible because of the long-term side effects. And then the other drugs, 6-MP, azathioprine, and the biologics are steroid sparing. So the classic scenarios, you'd start someone on steroids, try to get them feeling better, and then put them on some combination of these medications to try to get them off the steroids. You have increased risk of lymphoma and skin cancer, particularly with 6-MP and azathioprine, and combination therapy, 6-MP, azathioprine, and biologic. There's an increased risk of something called hepatosplenic T-cell lymphoma, extremely rare, but almost uniformly fatal disease, particularly of younger men. And so we're cautious about having someone on combo therapy for a long period of time, particularly if they're a young man. And then we want to screen patients, as we just mentioned, for hepatitis B and TB before starting any of these therapies. So where might you guys see some of these scenarios, right? So someone comes in with a small bowel obstruction. You think if it's related to inflammation, that's a good time to give someone steroids. Short-term treatment, try to get their inflammation under control to improve their small bowel obstruction. Someone has a fistula or perianal disease, generally speaking biologic, and particularly infliximab is the treatment of choice. You might need to give them some antibiotics if they have an abscess. You're trying to treat a little bit of infection. And then various combinations of the biologics and the immunomodulators for induction of remission or maintenance of remission. I think the sort of general paradigm is a little bit more complicated than we need to discuss, other than to say that 6-MP and azathioprine are not good choices for induction because they take 3 to 6 months to work if they're going to work at all. Whereas if you're using them in combination, really the biologic is the part that's helping getting disease under control. When do we think about surgery in these patients? The overall need for surgery is going down as our drugs have gotten better. The most common surgery that people get is an ileocolic resection. So they'll take out the bottom part of the ileum and the first part of the colon and then reanastomose things together. You may need to do this if they have an obstruction. Certainly if they have a perforation, someone's going to need surgery. Abscess, if they have cancer, they're going to need to have that resected. And then we want to think about what happens after we do surgery and assessing for postoperative recurrence. Basically, any of the factors that make someone higher risk for this disease to begin with is going to give them higher risk for recurrence of their disease. And so if they've had extensive disease, if they've had surgeries before, if they're younger or more severe disease, smokers, I tell patients all the time, the only thing they have control over if they have Crohn's disease is whether they smoke or not, right? They didn't do anything else to cause this, but smoking absolutely makes outcomes worse. And so if they can stop smoking, that is the best thing they can do, besides all the other reasons that smoking is bad for you, but for their Crohn's disease in particular. And then I'll generally think about repeat a colonoscopy 6 to 12 months after they do surgery to make sure things are going okay, either whether we have to start a medicine or change a medicine.